Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, my name is Katja Pinker. I'm warmly welcome you to this program titled Optimizing Breast MRI Surveillance in High-Risk Patients, Strategies for Repeat Imaging Excellence. And it's a great pleasure that my colleague Ritze Mann from Radboud University Medical Center, Amsterdam, the Netherlands, is joining us here. We will give you our opinion on what we think, how we can optimize breast MRI surveillance in high-risk patients, and talk about new exciting developments here. And I will also highlight what are teaching points with patient cases. The question is, what is different in high-risk women? There are a few things that are clearly different when a woman is at greater than average risk of breast cancer because they need different forms of screening. And what makes a woman actually at greater than average risk of breast cancer? Well, you could be a mutation carrier, that you have relatives that are mutation carriers, and you have an overall calculated lifetime risk of greater than 20% for getting breast cancer in your lifetime. You had a history of a chest or abdominal radiation at a young age, yeah, or even a personal history of breast cancer before the age of 40. And typically, women get offered an annual screening mammogram, which often nowadays is a digital breast tomosynthesis. But in those women, this may not be enough. Mammography is a sensitive test, but in particular in women that are denser, which are women that are younger, the sensitivity plummets. And also there are breast cancers that are mammographically occult. And in those women, we do the most sensitive test that we have. That is breast MRI. This is the most sensitive test for breast cancer detection. And the ACR recommendations for breast cancer screening of women at a higher than average risk is an annual digital mammography or digital breast tomosynthesis combined with an annual MRI, which then may be actually staggered to maximize the sensitivity and output that you can get from those modalities. And even other populations that are not at the highest risk, that have a greater than average risk but do not reach the cutoff of the 20%, women like with a history of atypia or just their very dense breast tissue, should be considered for this enhanced screening, because we know that in this patient collective, mammography is not enough. And if MRI is not available in those patients, we nowadays can even consider contrast enhanced mammography, which is sort of the same mode of detection than mammography. So, and with this, I will hand it over to my colleague, give you more background on this situation.
Yeah, I would like to talk a little bit on breast MR and how it works and what it actually can do. But also, I'd like to highlight for a second in the ACR guidelines that Katja just described the need to do risk assessment in women at the age of 25. Right? In the very high risk population, BRCA1, BRCA2, PALP2, and so on, we start screening from age 25, but you see that currently we miss a lot of patients due to the simple fact that they are not aware, or we are not aware of the fact that they are actually at that high risk. And obviously, many women only figure the risk out when one of their relatives is actually diagnosed with breast cancer, and very often too late because then they also already have advanced cancer. Um, the beauty of MR is that it is capable of finding cancers when they are really, really, really small. Um, I think that is also what makes or what highlights the added value of MR over mammography and DBT. In virtually all women, you find with MR cancer 2 to 5 years earlier than you would find it with conventional imaging, maybe even up to 10 years before a cancer would give clinical symptoms. And that earlier detection leads to a massive state shift where you basically see that cancers are, in essence, mostly T1 and 0. As a consequence, do not kill. Now, if you look at MR in annual screening, then the first question is, why does it work? Right? What is so typical about MR that it yields so much additional cancers? Because if you look at things like spatial resolution compared to mammography, it's actually not so good. The typical spatial resolution of a digital breast tomosynthesis acquisition is in the order of 80 microns, whereas MR is in the order of 800 microns or zero 0.8 millimeters. So that's not the gain, right? The gain is in the fact that we do functional imaging with MR. And the function that we tend to evaluate is basically perfusion. Um, because in essence, cancers cannot grow over roughly 2 millimeters in size um, without some additional vascularization. And if cancers grow relatively fast, those vessels are made in a hurry, right? Because the cancer otherwise would die from its own growth. So the vessels that are developed are usually not mature. They are leaky, they are tortuous, they have widened interendothelial gaps, as it's called. And due to the fact that these vessels are there and they are surrounding the cancer and they are inside the cancer, the gadolinium that we administer intravenously um, can go out of the vessels, whereas normally it's contained within the vascular space. And changes the magnetism locally in the extravascular extracellular space that surrounds the cancer or that's within the cancer. Um, Basically, these large gadolinium chelates do normally just travel in the bloodstream, right? So on a normal breast MR, if you look at it, you will see enhancement in the heart, and then you see the enhancement going into the mammalian arteries. You will see it in the big arteries to the arms and the veins, obviously, when it returns. Um, it usually also enhances lymph nodes, but in the breast, most of the time, nothing happens, right? The breast itself has some very tiny vessels, and if there's nothing going on in the breast, with classical breast MR is, aside from a couple of vessels, just black. And that makes the life of a breast imager very, very easy, because if it's white on a subtraction image, it should be somehow abnormal. Obviously, it's not always that easy, right, Katja? Um,
I wish.
No, no, I mean, we all struggle all the time with small lesions that do enhance that might or might not be something and that are potentially relevant. Um, but overall, it's typically the cancers that enhance early. And that's something that you should keep in the back of your mind. If there is contrast coming into the breast, way before the parenchyma enhances and way before you get this classic background parenchyma enhancement that sometimes also makes our life difficult, you see that the cancers enhance. What basically happens, what we call enhancement, is a shortening of the T1 time of tissue or of protons in the tissue. Gadolinium that we administer is not something we can see. Very different from iodine that you have for CT and also contrast mammo, where you actually see the molecules themselves. Gadolinium you don't see. Gadolinium changes due to the paramagnetic effects, the relaxivity of the surrounding water protons, and as a consequence, these align much faster in the magnetic field. This shortens the so-called T1 time, and as a consequence, the signal intensity on a T1 weighted image is much brighter. Um, so what we're looking for is changes in this T1 relaxivity, and as a consequence, the major and most important sequence of a breast MR scan is the T1 scan. And since some things are white from the start, things like blood, for example, or proteinous cysts, what we tend to do is we make subtractions, right? So we have an image before contrast, we have an image after the contrast, we subtract those from each other. And what we keep are the things that are really enhancing. These are tiny lesions and are usually also tiny cancers. The average size of an MR detected cancer after a first pass round is in the order of 8 to 10 millimeters, right? We should be looking for very small things. If it's 5 centimeters, something went really, really wrong. It happens once in a while, but it's not the intention. um, if you look at many studies that are out there that actually focused on MR as a screening technique, the first studies all looked at screening of very high risk women, mostly BRCA 1 and 2 positive, but actually up to a lifetime risk of 20%, as Katja just said. And there's two reasons for that. For one, we did not do very well with mammography in that screening population. But on the other end, and maybe just as important, if you want to set up a screening study, you want to find some cancers, right? And if you look at the average population, the number of cancers that are there is actually not so high. So you need to screen thousands and thousands of women to find a couple of cancers. If you screen the high risk population, you find much easier, much more cancers. And as a consequence, that is the population that has been best researched. Doesn't mean it doesn't work in other patients, but there we actually have the additional gain. If you look at what we find, then the relative sensitivity is usually given as the number of cancers that are found on top of a negative mammogram. And in the very high risk population, that is in the order of 20 to 30 per thousand more. In the intermediate risk population, it's somewhere between 10 and 20. Um, those are staggering numbers if you realize that the actual numbers that we detect with tomosynthesis are somewhere in the order of 4 to 6, depending on the frequency of screening, right? Maybe 8 if you go to Europe and have 2 year or slower screening programs, but on annual screening, it's about 4 to 6. So 20 on top of that means that we find cancers a lot earlier, and the relative gain in sensitivity is in the order of 200 to 300%. You could also look at it the other way around, right? I mean, we always say, okay, we need to screen with mammography or DBT and MR, and MR is regarded as a supplemental screening strategy. But if we do it the other way around, we screen with MR and then look what we find in addition with tomosynthesis, we're talking in the order of 5 to 10% of additional cancers, right? And those are usually low-grade DCS and very small lesions. So the bulk and the most important part of cancers in high-risk screening population is really found with MR. Initially, you saw that in prospective trials, but there's now massive retrospective cohorts that showed exactly that, every time, again and again, across the whole world. As Katja just already highlighted, we are facing a shortage of MR, not because we cannot offer MR to all women, because we would need thousands and thousands more MR scanners. Contrast mammography might be a useful alternative there, especially in the intermediate risk population, in women with a prior history of breast cancer themselves, in women that are less susceptible to radiation that would be induced by the mammogram in itself, and then patients that do not have issues with their kidneys because the iodine might otherwise be an issue. In general, I would say that contrast mammo might replace MR in some cases, but the other way around. And there are indications for MR that are virtually never resolved by contrast mammo. Doesn't mean that MR is the holy grail. There's plenty of women that really, really dislike going in an MR. We need to offer them something too. And that's also where contrast mammo might come in handy. In fact, for example, in the Netherlands, we ran a large study with questionnaires among 412 women at intermediate risk. That means 20 to 50% lifetime risk. And they basically said, okay, what we do not like about MR is the fact that you have to be in a small tunnel, that you have to lie down for quite some time. The table at some point starts simply to hurt. Also, the noise of the scanners is an issue still, right? It really makes a lot of noise. And then the injection of gadolinium is also not experienced as a pleasant sensation. Nonetheless, within these studies, if women can choose between mammography or MR, the vast majority chooses MR as the screening technique. So overall, that works quite well. And also, if you look at the perceived trust of the results of the scan, right? about 60% of the women that underwent a mammogram trust the results of the mammo, whereas 90% of the women that um, get a negative result on MR trust the results of the MR. Um, if you look at how many people trust um, a negative memo result, that's a little bit of a different thing due to the simple fact that if you undergo an MR, you have likely learned that memo is not fantastic. Consequently, offering MR reduces the trust of mammography a little bit. Um, what happens once in a while is that you have patients that are really, really anxious, that do not want to go in MR. Sometimes a little tranquilizer might help to actually get them at ease. Also, showing them the MR scanner might help in the beginning. And I don't think we have mentioned that before, but we used to scan protocols that lasted roughly 20 minutes or so. And currently, we have abbreviated MR protocols that are going down to roughly 5 minutes, due to the simple fact that the most important part is the enhancement part, and everything else can be sacrificed if needed. And if you look at current studies, the performance of MR is not going down at all. Um, the trouble with MR is obviously that we need to administer a contrast agent. That's gadolinium based. Gadolinium is toxic. So it's chelated to make sure that the toxic parts do not reach the body. Most gadolinium agents that we currently have are extremely, extremely stable and very, very safe. Accumulation in the brain, as we saw with the linear macrocyclic agents, um, of all days are currently hardly visible anymore. But if you really want to measure it, you can find minute traces of gadolinium in bones, for example. It is a sort of an analog to calcium, so it's logical that it is sort of stored there. Obviously, the better the molecule, the better for the patient. The less accumulation, the better it is. And with the modern high relaxivity contrast agents, um, these are one more stable, but they also have the huge advantage that we need to give less, right? Half doses are sufficient. And this has two large benefits. One is that we do not see the accumulation in patients. And if you have to go repeat after repeat examination, it really makes a difference in dose to patient. But it's also an environmental issue. We excrete gadolinium through our kidneys. And since these molecules are very stable, they come into the wastewater and we cannot get them out easily. And as a consequence, also for the environment, it seems very logical to use as little gadolinium as possible. Um, the current high relaxation contrast agents are gadopilinol and gadocotrain. They have a relaxivity that is roughly 3 to 2 times as high as the older good contrast agents. Before, we tended to use with gadobutrol, which actually had half the amount but still the same dose, and that actually has a very nice signal. But with these newer ones, we can actually further reduce the gadolinium dose. I think that is really very useful. There's several studies that basically show that if you use half of the dose of gadopilinol, you are as good as gadobutrol. Similarly, with gadoquantrain, if you use only 40% of the dose, you get more or less the same signal intensity as you would have with classic 0.1 millimole gadobutrol use. So overall, we can reduce the dose without harming the images, or actually maybe even getting better images. And that in itself is obviously something that is worth a lot. At first, each events with gadolinium are next to nothing, right? There are um, reported adverse events that come down to some headaches, some dizziness, some nausea, um, that just disappear the minute the scan is made. So there's very little long-term issues with gadolinium. Still would like to use as little as possible. And I think the whole story can only be discussed well if you just look at cases. And for that, I'd like to hand back to Katja because she has some beautiful examples of everything we are doing.
Yeah, and I'd like to underscore your point. I mean, the one thing is we are talking about here theoretically of screening healthy women. These are not patients yet. Yeah. And when you think about when we start as early as 25 and we're assuming that she has a very, very long life. Yeah. We're talking about annual MRIs. how many doses of gadolinium that over the lifetime of a patient, of a woman who hopefully never will be a patient. So that is like, I think it's extremely important just that we now have low dose gadolinium available, contrast agents available that give you the same image quality. And also, women are informed. They have access to these informations, they're informed, and they are very concerned that it might expose to that to unhealthy doses. Yeah. My first case is exactly that scenario. That is a high-risk screening patient who is a BRCA1 mutation carrier with an Ashkenazi founder mutation. She personally doesn't have a history of breast cancer. She was a young woman in her early 40s. From the family history, the mother had ovarian cancer, the grandmother had breast cancer in her 40s. So she is concerned. She is coming for annual screening. And what we do for screening, yes, we do a mammogram. You said, yes, we can also find some cancers, but in particular, in the BRCA1 mutation carrier setting, the additional cancers we are finding with a mammogram, honestly, are almost zero. There's actually a discussion or very nice publications from Riedel and JCO, which actually showed that in those BRCA1 carriers, you could theoretically forego mammography because these women present with the mammography occult cancers. What would you find? You would find tiny microcalcifications, which are low grade DCIS. Yeah. But when you have a look at her MRI, you actually see her clear as day in the middle of the right breast, a linear clumped non-mass enhancement. Yeah, this is like kind of like you already used the terms that describe a suspicious lesion. This lesion will have to go to in this case MR guided biopsy, because I mean when you look at her mammogram, she is very dense. You will not see this, and also the chances to find that linear non-clump non-mass enhancement with a second look ultrasound honestly is virtually zero. You actually see this lesion standing out, like you can on the T2 weighted sequences, the information, and you talked about it. Our workhorse sequence is the dynamic contrast enhanced exam, because on a T2 enhanced scan we do not see this. We need contrast to make those lesions pop out against the background, and also to highlight, or to your point, well, we have the contrast enhanced image from which we then subtract our mask to get the breast all black image. And then there we, with this particular, with this high relaxivity contrast agents, those lesions really nicely stand out. And so this is the way how we detect it. And often we even have to go to a MR guided breast biopsy to diagnose those lesions. And that often gives you then also the feedback loop. Where does your biopsy marker fall in those breasts? And you really know that you were not able to see them on a mammogram. And in this patient, this was a DCIS high grade, to the point. These women, that is what we want to find. We want to find them when the cancer is not invasive yet, when we can easily kind of cure those cancers. But a high grade TCIS, this is the cancer that will go on to become an invasive cancer relatively fast, as opposed to low grade DCIS, where there are now studies discussing what these even need to be treated.
What I really like about your this case, right, is that you show here how a radiologist can save someone's lives, right? This is
Yes.
really where we have the added benefit and where we make the difference.
Yeah. And I mean, the one thing is, yes, the mammogram, we have said it, like it can find you some additional things, but in this population, the MRI is the lifesaver. The neovascularity imaging, this is how you pick up those lesions. Yeah. And then the one thing is, they need to undergo that really repeatedly, because these cancers also can appear over short time. So the annual screening interval in these high risk mutation carriers is a reasonable one. Yeah. And with this, to the point, as low as possible with the dose, with the highest image quality, because we do need the highest sensitivity in those women. And I mean, the second case, similar story, 34-year-old young woman, high risk screening. In this case, actually, she was not a mutation carrier. She just had a very strong family history of breast and ovarian cancer. The one thing is, I mean, now we know about a lot more mutations than BRCA1 and BRCA2. In the beginning, it was those two mutations that made you a mutation carrier. Now we know there are other high penetrance mutations, intermediate penetrance mutations. I think our cohort of women will actually increase. our screening population, we started off, oh, well, 5% of cancers are genetically mediated. That was like 15 years ago. Now we're talking about 12%. This is a population that will grow. And now that we also know that like women that are not the 20%, but at a greater risk should get better imaging, we will have a lot more work to do, and we have to find out how we make our scans most effective. And in the second case, similar story. This woman is again heterogeneously dense. She has a dense breast. And this is the next thing. All these women, the young women, they are typically dense. So when we have the crucial time frame where, because when you're young, your cancers are aggressive, they kill women fast. Yeah. This is the time where we have our hardest time interpreting a mammogram. So this is like women are just underserved with mammography. While the older you get, actually your cancer risk kind of goes down, your breast gets less dense, so you are more able to be screened with mammography alone. But this is a case, another case. Both views, there is no cancer visible on the mammogram. Yeah. And on her MRI, we clearly actually see again a focal non-mass enhancement, kind of even a little bit of a linear component to it. Yeah. Again, second, the STIR image, the T2 weighted image, not helpful. Yeah, it is like in the sense, not helpful in the sense I would not be able to see the cancer on this image. When you now ask a question why we're actually doing T2 weighted imaging when it is not helpful, well, it adds specificity. There are lesions which we see that enhance, which have a benign morphology, like a lobulated round mass where we're thinking this is most likely a fibroadenoma. Yeah. Then if this lesion is also T2 hyperintense, that is supportive of that. Yeah, so it adds specificity, but it will not find you the cancer. The sensitivity comes from the contrast enhanced exam. T2 is added specificity. And also, if you have, because we know that in particular, high risk women, BRCA carriers, can present with lesions that from the morphology would be suggestive of potentially of a benign lesion. Their T2 adds you something when this lesion then is not T2 hyperintense, but has a perifocal edema. No benign lesion has, so should have a perifocal edema, peritoneal edema. So that gives you indicators. So there is a reason why we're doing more than one sequence with MRI. And in this case, this patient underwent an MR-guided biopsy of this focal non-mass enhancement. And this is what we want to catch. We want to catch the very tiny lesions before they get invasive, before they are big, before they spread. Yeah? And in this case, we did an MR-guided biopsy, and this was again a high-grade DCIS in this patient. So there are other scenarios which we have talked about, because the first two examples were clear-cut high-risk women. Yeah, and then also Ritzi also spoke a little bit to that. We also have changing our ways of how we are assessing risk. We have this 20% is a lifetime risk. Yeah, we're now also looking at women when we have other tools like artificial intelligence to predict from images the risk. We are also diving into the near-term risk. Yeah, so what a woman will, how likely is it that she will get breast cancer within the next 5 years? So our pool is enhancing. We have women that are greater than average risk. Um, these need also more. And this is the next case, is a 44-year-old. She is a greater than average risk of breast cancer. She had a status of a benign breast biopsy already, and she's undergoing screening. In this case, she didn't really make the 20%, but she needed more. So she underwent a contrast enhanced mammogram. Contrast enhanced mammogram has the same way of visualizing cancers, in the sense that with the contrast agent, we visualize neovascularity as a tumor specific feature. And in this case, I mean, and I think this is to the point, that the most sensitive test, and it is a 3D exam. A contrast enhanced mammogram takes a 2D picture of a 3D structure. So this is like, there will be overlap, there is superimposition, and the most sensitive test is the MRI. In this patient, we had actually a queried, we saw something. We had a queried ductal enhancement in the left breast. This is like we see here, there's not much background enhancement, but on the left breast, there was the impression of, could this be a ductal distribution of these enhancements? So in this case, what do you do? That was honestly, that was the time before contrast enhanced mammobiopsy. So what in this time, we would in general go to an MR as the next step and see if we do see still see an enhancement and have a biopsy target. We nowadays still do that. If it's a questionable enhancement on the contrast enhanced mammogram before you then straight go into contrast enhanced biopsy, we still go to MRI, because if the MRI is negative, we are sure that this is nothing and can send her into a follow up with a contrast enhanced mammogram in 6 months. But in this case, that was very truly an enhancement. And here we really nicely see a ductal, even branching non-mass enhancement in the left breast. Yeah. So to the point, this is like one kind of clumped ductal enhancement stretching from retroareola in the anterior middle part of the breast. Yeah. And this is obviously a concerning finding. And this then underwent biopsy. But the thing is, here you really very clearly see that it's kind of like way easier to appreciate than in on. But in all fairness, the contrast enhanced mammogram, to the point, it visualized the cancer with neovascularity. But if you have the if a woman can undergo an MRI, if insurance is covering it, um, this is still, I think, the most sensitive test, and ideally you would go for that. And I think it's here there's a side by side comparison where you really see how on MRI you see this beautiful clumped ductal enhancement that you can kind of appreciate on the contrast mammogram, but MRI is the most sensitive test. So when we're talking about high risk screening, the question always comes up, oh, can contrast enhanced mammography not just replace MRI in this context? If you are at high risk of breast cancer, the test to go for is an MRI. And we do best efforts to make it more accessible with shorter protocols so that women can be in and out of the MRI suite faster. There's movement towards different coils that are more comfortable, like wearable coils. So there, I think we will see a lot of movement. And the crucial part is also the contrast agent that we are offering to those women. I think we both agree that if you're at high risk of breast cancer, you should be able to have an MRI, and that this high radioactivity, particularly low dose agents, are really helping our cause here.
Yeah, definitely. I must admit that I'm really impressed that someone picked up that cancer on a contrast memo. But still, yeah, there is simply no test that is as good as MR at this point in time. But we come close, and I really think that it is important that we realize that to make things accessible and easy, getting short protocols, getting good contrast agents really is important, and making it actually a little bit less noisy and a little bit more comfortable would also help. I think in that sense, we still have some work to do for the coming 10 or 15 years. Um, I think overall there are a couple of key points that follow from our discussion that are really important. If you have women that are at high risk for breast cancer development, make sure that there is a possibility to screen those with MR, right? Make sure that you offer it. Make sure that it's accessible. Do the negotiations with the healthcare insurers if it's needed. We are saving lives with that. And the other thing that is maybe important to optimize the comfort and use as little contrast agent as possible. So as a consequence, it's important to optimize your contrast use as well. I think if you realize that and do your best to bring that to practice, um, in combination with short protocols, MR can really be a game changer for many women out there. And actually is one of these things where, as radiologists, we can really claim we are saving lives.
I can agree. I only agree. And I mean, the one thing is we are already saving lives. Yeah, with like for a lot of women, we just now have to make sure that we really select all the women that they needed, because I think there's a lot of women who are do not get the risk assessment, do not have the appropriate access that they should have. Yeah, I think like this is to your point. We need to make sure that we women who really need it get the access to it. It covers a spectrum that is underserved, where we still struggle to give them the better test than only morphologic imaging with a mammogram.
Very true. I really think that function is what currently makes the whole difference in breast imaging, and not only in the setting of screening, but also in staging patients with breast cancer, for example. I think we are at the end, right?
Yes,
Yeah. That,
I believe so.
that
Yeah, well,
points of
great discussion. Thank you.
Yeah, it's great if people are listening, and thank you all for listening to us. I hope you really learned something from it. Um, with that, also don't forget to fill in the evaluation form. And um, thank you once again for looking at this session.
Thank you.